morning. Oh my goodness. Good morning. Thank you. My name is Dr. Bridget Muller. I am a pharmacist by profession, currently working as a senior associate at Africa Health Business, and I'm from Kenya. I am very much excited to be here today and to see each and every one of you make it to the last day of the conference. Are you all excited? Can we do that better? Are we all excited? Perfect. So this is the last plenary session, so I'm told. So I intend to make it the most fun plenary session for today. Now, this session, we'll be talking about primary healthcare delivery and transformation. So I was prepping a bit yesterday and today morning, and I just decided to look at the program for the whole conference. And do you know what I realized? I realized we had 2 abstracts on primary healthcare. We had 8 side events on primary healthcare, and we have a whole track on primary healthcare. What does this show us? It shows us that primary healthcare is very, very important. And I know one of the big things that we're talking about is how do we actually achieve UHC? And you know, we can't do that without primary healthcare. So I just want to quickly go through what's expected of this session. And the main message that I'd like you to carry today from this session, if you at all forget anything about this session, I just want you to remember that PHC is non-negotiable for UHC and health security. I happened to attend some of this primary healthcare session. I was actually part of the organizing team of one. And I was making fun of Dr. Lucy, who will be speaking later. I was just asking her, how many sessions have you actually spoken in? Because it seems like I saw her in a lot. So I was telling her she's slowly becoming a PHC champion. So I do hope each and every one of us, as we're leaving this room today, we're going to leave here as PHC champions, and I know most of you are probably are. We've talked, those 8-10 sessions that the conference had on primary healthcare, I sat down and I was like, I thought I knew a lot about primary healthcare, but goodness, I was just, you see how when you hear nuggets in a room and you want to snap? I was probably doing that internally because the information was really, really good. And I probably have to go and read a bit more when I go back home. There is so much on primary healthcare information. For this session, being the last plenary session, I would like it to be action-oriented. What are we going to do about this when you're coming out of here? From the speakers and also to the audience, because we're going to have a Q&A session. So I'll be your moderator for today, and I am more than honored to be co-moderating this session with the one and only Deputy Director, Africa's CDC, Dr. Tajuddin Raji. I'd like to welcome him on the stage as he takes us through the next part of the session. And maybe as he's coming, the session I did, I introduced a really nice clap, so I want us to be a little bit savvy when we're clapping today. It's called the Parliament clap. So this is what we're going to use for the session today. So you clap 1, 2, 3, 1, 2, 3. Can we try that? Perfect. Can we give Dr. Taji a clap? Better, thank you.
Thank you so much, Bright. Your Excellencies, colleagues, ladies and gentlemen, let me, on behalf of Africa CDC, welcome you to this very critical plenary session, which is all about primary health care. As we all know, when it comes to health security and universal health coverage, PHC is that coin. Those two sides speaks to health security and universal health coverage. So meaning that that is the route towards, achieving health security sovereignty of our member state. I'm sure we have also heard severally during the course of this conference that the development assistance for health is fast declining. So also our debt servicing obligation. And the Abuja target is far from being achieved as far as most of our member states are concerned. In fact, only 3 member states have consistently achieved that 15% as put forward by our head of state and government around 24 years ago. And on top of that, our primary healthcare delivery system still remains very weak. So, to really unpack this agenda, to look at what sort of financing mechanism do we need at this stage, to drive the primary care delivery system agenda forward? How do we better leverage the digital technology to drive our PHC agenda? How do we use the PHC to address the staggering statistics as far as maternal, newborn, child, adolescent health, is concerned in most of our member states? And last but not the least, the so-called silent pandemic, antimicrobial resistance. How do we really put our PHC together in such a way that they're able to address this AMR issue that is already, taking a very, bad dimension as far as most of our member states are concerned? So we have 4 distinguished speakers this morning, 4 distinguished panelists who actually need no introduction, as far as PHC and global health in general is concerned. So to set the ball rolling, I would like to invite somebody again that will say need no introduction, talking of Amit Taka. And Amit, as we all know, is the CEO of Africa Health Business, and Amit will be taking us through what do we mean when we say resilient primary healthcare system, and how do we leverage innovative financing and smarter solutions to be able to achieve universal health coverage on one hand and health security on the other hand. So allow me or join me in welcoming Amit Taka to take the podium and give us 10 minutes, remark on PHC financing.
Thanks. Thank you so much, Bridget and Taj, for setting us up for this final plenary as we prepare for closing this amazing CPHIA event taking place here in Durban with a topic that's very critical. As our moderator mentioned, I've got 10 minutes to talk about 2 fundamental areas and 3 subsectors. So I'm going to really try in these 10 minutes to talk about innovative financing and smarter solutions, these 2, and from the perspective of engaging health actors for shared commitment and responsibility under the topic that we all gathered here of UHC. Let me start with UHC generally as we try to address the 2 solutions that I want to speak about as I end these 10 minutes. UHC means probably different things to different people at many times of the conversations that you've had. Probably even in different countries, you've had different conversations about UHC. In fact, so much so that some people do call it universal health care. You might have even heard some people saying universal health care. And that has a different meaning if you're looking at universal health coverage, which technically many of you understand is what defines the entire conference for which we are here present. But anyone who talks about care and coverage eventually means that there should be access to healthcare without financial burden. There are a couple of things that I do want to mention as the bedrock of UHC before I talk about the two solutions that I'm addressing. Primary health care is the foundation of UHC. That foundation on which you will build a safe, resilient health system which has components that are easily achievable, measurable, and the goals are smart. At primary healthcare level, everywhere in the last few days that we've gone to in different sessions, it's clear that healthcare starts at the homestead and not at the hospital doorstep. There is a huge amount of preventable and community health that can reduce the health burden that we currently face across the continent. Ask anyone who is a provider across the continent, and they will tell you that almost 70% of the ailments at the outpatient level are preventable. And if we deal with these diarrheal diseases, URTI, cough and colds, it'll be very impressive on what we can do with our limited resources for other ailments and NCDs. The second key point around UHC is prevention. Again, I've heard so many of you talking about this exceptionally well. And we have highlighted that prevention is better than cure. It's also cheaper than cure. And several discussions around self-care has come through. Remote monitoring of patients, using appropriate digital health, using dashboards to make sure there is no loss of treatment, and being very focused with what the community and the providers on ensuring that screening practices are scaled up to ensure we don't have late-stage conditions reaching hospitals that become a huge burden to the system. We've also heard of immunization. We've heard in some of the sessions, it's not vaccines that save lives, it's vaccination. And having the right commodities at the right time in the right place are all broadly defined as preventive and promotive health. So as we think about these objectives, that's the second component that I wanted to bring through. I have two more that I think have come out through all these sessions before I talk about the solutions. The third component around for UHC has been around financing, finding the right amount for the population and citizens. What is adequate and what is enough? And how should you actually spend per capita on per person to achieve appropriate health care? United States spends close to $10,000 per capita. Europe has an average of $4,000 per capita. And many of our countries in Africa hardly reach $100 per capita. Now you can imagine, do your mathematics and see what you can and how we can produce better health for the limited resources that are there. This means we have no room to waste. Whether it's public sector or private sector, state or non-state, every health dollar matters. In fact, every health dollar matters to such an extent that the cost of misuse and the cost of inefficiency is equal to loss of lives. There is no room to have financial misappropriations, but more importantly than misappropriations is priorities. Priority setting by countries on their financial matrix of health will determine outcomes and life expectancy. There's a direct correlation between priority setting, financial monitoring. That was my third objective that I wanted to bring out. The fourth objective under UHC that I want to end with before the solutions is the whole aspect of the geographical barrier. It's so stark. Many of the sessions I went to, they talked about health workers. We spoke about services availability, access. We spoke about many remote towns, locations in many of our countries in Africa which are underserved. We cannot leave the underserved population under the hashtag leave no one behind. The geographical barrier is a real issue. Not only supplies and commodities and health workers, but also ensuring that policies that are set in the capital cities or at the big towns do reach the remote towns appropriately. There is a leapfrog effect that Africa can show the world, just like it has done with the mobile technology and mobile banking. We overtook many countries around the world when it comes to mobile banking. The M-Pesa from the country I'm in, Kenya, was a clear example where you don't really need cards like they are in developed worlds, but we had even a better system than credit cards to engage and create entrepreneurs and create an economy that will be inclusive and is affordable. That leapfrog effect we did with the mobile phone was incredible. Can we do that in health? So what's the M-Pesa for health? So the digital health solutions that we are all talking about lends us with an idea of bridging the geographical barrier and the geographical divide. So I really hope that some of the action plan that we talked about, as the moderators mentioned, is to have a strong digital health strategy that is effective, actionable, and can be measured for us to reach the unreached population, because digital promise is what's going to take healthcare closer to the communities rather than trying to ask more specialists to travel upcountry and places. As I close, let me take these few minutes to just mention about innovative financing and smarter solutions. For resilient systems, I am pretty clear that we, with the declining donor support and overseas development agency engagements and aid, it's critical for us to start looking inward for domestic allocations and have greater ideas around raising more ring-fence financing for health. Here are a couple of thoughts. You all understand and have engaged with bonds. We need to design a bespoke bond in Africa for health. The healthcare bond will be solid, will be country-specific, will have ring-fenced models that will provide primary healthcare the components it needs and have citizens participate strongly to ensure that in tandem with the treasury allocation, there is money that is dedicated to healthcare. It's one of the tools we could explore, and the economists in our midst can explain a little bit more on how we can raise that. The second one is around engaging all the corporates that operate in Africa on an allocation of a 1% model. 1% of overall profits to be dedicated towards healthcare within their own country can go a long way. The third innovative financing model is around crowdsourcing. There are several well-wishers. We all know about philanthropy and CSR, and crowdsourcing is having individuals participate in community health. That organized health crowdsourcing can provide us a buffer fund for villages, for communities, and indeed for the country. And you've all participated in CSR. And CSR stands for Corporate Social Responsibility. We want to change that word in Africa. We want to call it SRC. So we are moving from CSR to SRC. SRC is socially responsible corporates rather than corporate social responsibility, where we now have every organization, every entity becoming an SRC labeled entity that will provide us innovative financing towards this partnership. Smarter solutions are solutions that will integrate AI and digital space for UHC models. With this, ladies and gentlemen, I think health actors, shared commitment, and responsibility for UHC will definitely be a reality. Thank you so much for giving me this opportunity to set the stage on this particular topic of innovative financing. Taj, back to you.
Another round of applause for Amit. Thank you so much for that. That remark. You underscore the centrality of community when it comes to primary healthcare delivery system. You talked about preventive medicine with emphasis on vaccination and immunization. It's not about the vaccines, but it's about immunization. And of course, you talked about the importance of service delivery from a distance, talking of telemedicine. And you said we should move away from corporate social responsibility to social responsibility corporate. You know, again, we heard you loud and clear. So, colleagues, ladies and gentlemen, at this point in time, allow me to invite Our Excellency, Dr. Christine Kaseba, former First Lady of Zambia. She will be talking to us about the role of primary health care in maternal, newborn, child, and adolescent health towards universal health coverage. So, Your Excellency, I'm trying to, all right. Thank you so much. Please join me in welcoming Our Excellency to the podium.
Thank you, moderator. And let me start by thanking the organizers for having given me this opportunity to talk about a subject that is very, very close to my heart. I'm glad to stand here as a woman. I hope it's obvious. I stand before you as a wife, even though now I'm widowed. I stand before you as a mother and a grandmother. Therefore, I am a very interested and biased stakeholder in the outcomes and aftermath of this conference. We are here to talk about challenging the current status of health for mothers, adolescents, and children. Before I start, I would love to invite everyone to reflect critically on where Africa stands in advancing the health of mothers, children, and adolescents, and how we can move beyond incremental progress to systemic renewal that centers equity, resilience, and the people. I've been a champion for women's health, and I would have loved to speak about women's health because when we talk about women's health, we're not just talking about hospitals. We're not talking about our uterus. We are not talking about the hormones, because a lot of times women's health is usually synonymous with reproductive health. But I wanted to clarify that women's health is much more than reproductive health. It's about a full spectrum of a woman's life, her body, her mind, her choices she makes, her safety, and her place in society. So it's considered a holistic approach to recognize that women's health, the needs evolve across different life stages from pre-birth through adolescence, adulthood to menopause and beyond. But today, because of limited time, I'm going to focus my discussion on maternal health. What's the current status of health for mothers, adolescents, and children? Looking at the statistics on this slide, we can all agree that Africa has made some progress. Since 2000, maternal mortality is down by 40%. Child mortality, newborn deaths, under 5 mortality, they've all declined by around 33 to 35%. And interestingly, universal health coverage index has improved from 45 to 68. Yet, in the last few years, we have not sustained this progress. Progress has stalled. Africa still accounts for 70% of global maternal deaths, which translates into over 550 deaths every day. Every day as we sit here, we're losing 550 women. Neonatal and under 5 mortality remains above global targets. Non-communicable diseases are on the increase. And just when countries were patting their backs that they have conquered HIV/AIDS, the infection rates amongst adolescents are on the increase. And this is worrying. Adolescent birth rates in sub-Saharan remain very high at about 103 births per 1,000 adolescents. And it's disheartening that for adolescents, the biggest challenge is data gaps. We still do not have enough data on adolescents, and this limits our response for care. So we are improving, according to the slide, but not fast or fairly enough. Hence, we cannot afford complacency. Hence, we need a revolution. What are the root causes of the status quo? The big question is, why are we stuck? We are stuck because we are yet to understand that primary health care is fundamental to achieving universal coverage. Our primary health care systems remain weak and underfunded. Despite evidence of improved uptake of preventive services when vertical services are integrated, integration of services into primary health care has remained a challenge and very uneven. And this is compounded with health workforce shortages and burnout. It is estimated that by 2030, Africa faces a 6.1 million health worker shortage. and an anticipated deficit of 500,000 midwives by 2035. This has been also exacerbated by various disease outbreaks, limited community engagement, and lack of cultural alignment, which compounds the status quo. For so long, we have built systems around disease, not around people and their culture. We have not used the life course lens to connect the dots between health beginnings, empowered youth, and resilient adults. So what will it take for us to achieve this primary healthcare revolution? And I must state here that the concept of primary healthcare is not a nostalgic idea. It is a revolutionary concept. Revolution means reimagining how care reaches people from top-down programs to community-driven systems. It requires a fundamental shift from curative to preventive, from centralized to community-led, and from fragmented to integrated systems. And we need to understand that primary health care is not just about being first line of defense against disease outbreaks, but it is the foundation for health security and resilience, just as Amit stated, the last speaker. Listening to many presentations in the last 2 days, my work was made easier because the message was very loud and clear. We know what we need to do to embark on this primary healthcare revolution. We need to build community and human-centered primary healthcare. We need to empower and invest in community health workers and mid-level providers, integrate maternal, child, and adolescent health services, and strengthen data collection. The picture, you have the top picture. I don't know whether we have, I think we have, okay. The laser is not working. As a first lady, I championed cervical cancer screening, I championed family planning, and despite the knowledge going up, despite the awareness being raised within the community, despite the public media messages, the numbers were still very low because people were afraid to go to the hospital because they were going to be made to pay. Even though this was a free service, people never attended the clinics. So I suggested permission to use the mobile hospitals that had been bought by the previous government. And there is a political story to these ambulances, but I won't go into that. That is a story for another day. But anyway, my husband grudgingly agreed for me to use the hospitals because he had vehemently opposed the purchase of those hospitals. So we set up camps, outreach camps in rural areas. And it was amazing that without anyone going into the communities to tell them this service had come, I mean, they knew that the service had come. The first day we went to start the outreach, these are the kind of lines we found. A multitude, hundreds of women had turned up to be able to be screened for cervical cancer. And as we continued in different locations, men came up and said, "Why are you leaving us behind?" So we had to attach the prostate cancer screening as well to the outreach services. Moderator is looking at the time. Now you can start counting your 10 minutes. And what we did as well, apart from offering services, apart from also offering curative services, I am an oncology surgeon, so we were able to start cutting the waiting list for people waiting for cancer surgery through these mobile hospitals. But at the same time, we also took time to build capacity, of the local health workers that we found. So the picture below shows me trying to teach somebody, don't worry about the lady who is supposed to be a patient. She's actually a sister in charge. We're using humanistic models to teach. But as we left each community, we made sure that there was capacity for them to start continuing. Nurses were being trained to do uterine evacuations. They were being trained to manage postpartum hemorrhage. They were being trained to do a lot of things, family planning. So at least it was a holistic. And I think it's important that as we think of a revolution, we don't need the mid-level providers because they are the front line to patients' care. And I think the Ethiopian Health Program has clearly shown that being done. Okay, I think we continue with primary care revolution. Other ways of ensuring that revolution is done is to identify greater domestic resources for health financing. And I must thank Amit for the wonderful solutions that he has alluded, and I think it was wonderful to hear about bonds. And women can be empowered to make a living as well as make sure that they are healthy. I think the other important thing here is viewing mothers, children, and adolescents as partners in health. Nothing about us without us is something that we normally hear in all these meetings. And women, youth, and communities are partners, not just patients. We must trust them to do what is right about their health. We need to engage mothers because they will be able to strengthen surveillance, accountability, and trust, and the lifeblood of resilient systems. When we're doing the cervical cancer screening, we used a bit of digital innovation, and patients were being given flash memories of their cervix when they have the first screening. And it was amazing that at follow-ups, if a nurse made a mistake and pulled up a different cervix, women themselves were able to say, that's not my cervix. And this happened. Women went out and they talked about what they had seen. Those that had a problem would be able to appreciate the changes on their cervix, and were able now to start telling other women. So we used those women to make sure that they reach the message to other women who were not there. Suddenly, people, started talking about the cervix, a cervix which is very hard to see under normal circumstances. But women were able to identify their cervixes through this digital innovation. And it truly puzzles me how governments, regulators, and even health professionals trust a woman to inject herself with insulin, trust a woman to inject herself with subcutaneous Ozempic, trust a woman to inject herself with Clexane, yet somehow believe it's unsafe for her to administer a simple subcutaneous Depo-Provera. We trust her to manage chronic diseases on her own, but deny her the agency of her reproductive health. We know postpartum hemorrhage is the #1 killer for maternal mortality, yet we are hesitant to let her take oral misoprostol just in case she delivers at home. We need to be honest. The issue isn't safety, it's control, and control over the uterus, period. So we need to move away from this concept. Health is everyone's business. Whether you look at it from schools to work or to farms or workplaces, we need to embed health in all policies and sectors. A health workforce, educated children, and nourished families form the backbone of development. Listening to a lot of presentation, there was more that has been covered, as you saw from the slides, But I thought I should talk about the agents of change, which was not really tackled in most of the presentation. When we speak of primary healthcare revolution, we often think of doctors, we often think of nurses, lawmakers and policymakers. But revolutions are not built in boardrooms, they are built in the communities. And in Africa, two voices can move hearts and systems alike. I'm talking about the voice of the First Lady and the voice of our traditional leaders. There's a First Lady on the first picture trying to change perceptions about cervical cancer. And in the last slide is a chief who really came out to help the campaign on HPV vaccination. There were so many rumors, so many myths about the dangers of HPV vaccination, and we are not making any headway. But when she came, she brought a granddaughter to be vaccinated, and suddenly the community in Chongwe changed. The children themselves started screaming, wanting HPV vaccine. Those that were cut off wanted HPV vaccine. And we have seen, even in the fight against early marriages, it's the chiefs in Zambia that are leading the campaign, who are pulling women, the young girls, from early marriages and sending them to school. So it's very important that First Ladies are not left out. They have the power to turn attention into action. Their platform can humanize statistics, because oftentimes we get our heads buried in statistics. We forget that these statistics, behind these statistics, there are faces. So First Ladies have that chance to do. I mean, we don't forget that they have the ears to the highest office in the country. So please don't hesitate to use them, because not all of us are going to be able to meet the presidents, but the First Lady is always there. Otherwise, she would deny conjugal rights to the president if he doesn't hear. Chiefs, on the other hand, carry the authority of trust. When a chief says, take your child for vaccination, when a chief said, deliver in a hospital, communities will listen. So together, First Ladies and chiefs can mobilize, educate, and hold systems accountable. And I think also the one that is overlooked, we always thank the media, but we don't usually seriously consider them in the fight or in any primary healthcare revolution. PHC will thrive when people see, when people hear, and people understand. And that's where the media comes in. In a PHC revolution, media is not optional. It is the engine that will drive the change. So in a nutshell, there are many agents of change at every level. We need to make sure that we don't leave anyone behind. Quickly, I think my time is almost done. Across Africa, countries are demonstrating what's possible. So when you look at what Rwanda has done, you look at what Nigeria, Kenya, Zambia, they are all doing, it clearly indicates that Africa is not waiting. Each example reflects a shared truth. Africa's solutions are already within reach. They just need scale and sustained political will. And listening to the Director General of CDC Africa, the WHO Regional Office Director, and our Minister, ably represented by our Zambia's own champion, Honorable Elijah Muchima, I'm convinced that Africa is on its way to primary healthcare revolution. We are indeed innovating our own path to universal health care. So in conclusion, finally, I'm sure the moderators are getting agitated looking at the time. We need to build systems that promote health, not just treat disease. Systems that are community-centered, inclusive, and data-driven. Wherever we stand as health workers, youth leaders, or advocates, we each have a voice and responsibility to champion this revolution. Many people have asked why and what made me start championing. 35 years today exactly, 25th of October, at just 28 weeks, I nearly lost my life. A tiny baby girl weighing only 900 grams was delivered by cesarean section. Against all odds, thanks to the dedication of doctors and nurses and the knowledge that I had on prematurity, she survived. She grew, thrived, and today she is a healthy mother of 2. So that's a young girl there. And that's why I speak out. And that's why we need primary healthcare revolution. A system that is accessible, equitable, and responsive to the needs of every community. Wherever you are, whatever your role, we all have a voice and a responsibility. Together, leaders, community health workers, and advocates, we can ensure that no woman's life is left to chance. The story of my daughter is proof. With care, with commitment, collaboration, what seems impossible becomes possible. Primary healthcare revolution may look impossible and far-fetched, but it is possible, and I believe this is Africa's moment to move towards self-reliance, to achieve universal health coverage and health security. And before I end, finally, I would like to just sincerely thank Abeli Wright for the wonderful input she put into this presentation. Thank you very much.
Guys, I think she's deserving of the Parliament Club. Was that it? Let's try it again. 1, 2, 3. 1, 2, 3. Perfect. Thank you so much for challenging the status quo in regards to health for women, adolescents, and children. Now, the next speaker will be talking about AMR, and even as I invite her, being a pharmacist, we are the custodians of drugs and a lot of things in the community. And AMR is such an important topic. Do you know how long it takes for a drug to get into the market? Let's say Panadol. From drug discovery, when they're doing the research in the labs and everything, to the time that you can actually take the Panadol at home. It takes 20 years, unless it's special case for emergencies like COVID and all that. And we need that because it's human lives that we are dealing with. So we have a lot of drugs, by the way, probably in research for a lot of the diseases, but we can't use them because they're not yet authorized. So we have a limited number of drugs right now to use. Imagine you're in hospital and you're being told you can't use amoxicillin because you're resistant to it. And we don't have any other drug because it's probably not in the process to be launched. Guys, we have a crisis called AMR, and if we don't do anything about it, we're going to have a big problem in future in terms of dealing with the drugs that we thought we had already sorted them out. Now, I would like to invite Dr. Mazianga Lucy Liwewe Mazaba. I was just calling her our PHC champion. She is the Regional Director for the East Africa Regional Co-Coordinating Center of the Africa Centers of CDC, and she will be talking to us about combating AMR in Africa. Can you give her the clap? 1, 2, 3. 1, 2, 3. Perfect.
Wow. How do you speak after such eloquent speakers prior to this conversation? Allow me to just acknowledge in the room everybody who is present, recognizing your capacities, but also a shout out to people who have had an influence on my career. Professor Luo is in here, I think she's known me since I was 24 and has helped prop me to where I am. People like Dr. Nantalile Mugala, who was a pediatrician to my first child, but continues to be a great big sister. And people who've taken over my career now, like Amit Taka, though in the private sector, very influential in the agenda for the Africa CDC. And I also acknowledge my seniors in the room, Dr. Taj, the DDG, and Professor Ngashi. A very interesting topic, and also because I actually have a very scientific background, having done a lot of work around virology. And AMR sort of came in because I also had a background in bacteriology. Antimicrobial resistance is one of the greatest public health threats of our time. And I think this has been said severally in many conversations. And what we see is that it quietly erodes the progress that we've made in healthcare, in making once treatable infections deadly again. And to set the tone of my conversation with you today, I want to quote a leader in the health sector, the former Director General of WHO, Dr. Margaret Chan. And she said this, she warned us over 11 years ago in 2016. She said, antimicrobial resistance is a global crisis, a slow motion tsunami, superbugs resistant to nearly all currently available medicines already haunt hospitals and intensive care units in every region of the world. On current trends, a common disease like gonorrhea may become untreatable, and we're seeing that today. What we must see now is the action. So we've been talking about this for a very, very long time, and yesterday, I think when I was talking to Professor Luo, there was a colleague of hers, I just can't remember the name, and she talked about how many years ago, this was a serious conversation and action plans were put in place, different strategies, and yet today we're still talking about the challenges we face around AMR. We see that AMR represents one of the greatest threats to global health and indeed development. And in Africa, where infectious diseases already exert a heavy burden, the growing resistance to antibiotics, to antivirals, to antifungals risks reversing decades of progress in public health. We are witnessing what we call a silent pandemic, one that kills slowly but persistently, eroding really our capacity to treat common infections and complicating routine medical procedures. The challenges are multifaceted. We see limited laboratory capacity and surveillance systems to track resistant pathogens. We see inadequate infection prevention and control in our health facilities. We see unregulated access to antimicrobials and misuse in humans, in animals, and even in the environmental sector. And I think that our moderator talked into that already. But also we see critically low levels of awareness among both health workers and our communities. But gladly, there is hope. There is hope because there's a lot of innovation that is going on. And even on our continent, we see very encouraging progress. We see the expansion of AMR surveillance networks under the Africa CDC's Pathogen Genomics Initiative, for instance, efforts to strengthen national action plans on AMR in alignment with the One Health approach. We also see innovations in rapid diagnostics, antimicrobial stewardship, in local manufacturing of quality-assured medicines. We also see a lot of good partnerships with academic institutions and the private sector to accelerate research and data-driven solutions. Importantly, we're also learning from our own experiences. And we saw in the COVID-19 how, we learned from there that when Africa leads with its coordination, community engagement, and services, we respond effectively and reshape the narrative. And we saw that in a number of member states that were responding to the global pandemic. But we need to go further. And so combating AMR requires transformative leadership, leadership that aligns actions across human health, animal health, and the environment. We've been having conversations around the One Health approach, but in many spaces it still remains a theory as the different sectors work in silos, even when they are, in close vicinity to one another. It requires a policy coherence, it requires adequate financing, and the empowerment of community health workers who from the front line of primary health care delivery. Ladies and gentlemen, because of the real battleground against AMR, because the real battleground against AMR is not in the tertiary hospitals, it is in our clinics, it is in our pharmacies, our farms, and indeed our own households. We need to put some attention to it at all levels. It is where antibiotics are prescribed, dispensed, and consumed that we have challenges. Therefore, as I come to the conclusion of my remarks, I want to emphasize that we need to integrate AMR prevention and control into all primary health care programs. We need to strengthen community-level surveillance and infection prevention. We need to ensure rational use of antimicrobials through training, through policy, and indeed enforcement. We need to invest in water, sanitation, and hygiene, WASH, which is usually outside the health sector, but needs to be emphasized because we are at the end of responding to a lot of WASH-related challenges. And yet, WASH is the simplest and most effective AMR intervention. Lastly, we need to champion behavioral change. We need to continuously communicate with our communities, our healthcare workforce on the risks of poor management of these antimicrobials. Ultimately, ladies and gentlemen, the fight against AMR is a test of how well our primary healthcare systems can detect, can prevent, and indeed respond to health threats at the community level. So if we get our primary health care right, with strong surveillance, rational prescribing, infection prevention, and empowered communities, we will not only preserve the power of antibiotics, but also accelerate the transformation of our health systems towards universal health coverage and resilience. Together, ladies and gentlemen, distinguished guests, let us commit to an Africa where our primary healthcare systems are not only accessible and equitable, but also strong enough to outsmart resistance, ensuring health security for generations to come. Thank you very much. Merci beaucoup. Siyabonga. And where I come from in East Africa, we say Asanteni Sana.
Thank you so much, Dr. Lucy. I would like to call back my speakers to the stage for an open forum discussion. So are there any questions already? Oh, one question only. Interesting. Oh, 2, 3, oh yay. Nice, nice. So we'll take the first 3 questions.
So, colleagues, excellencies, ladies and gentlemen, another round of applause for our distinguished panelists. So it's now time for Q&A. We will appreciate if you can keep your questions as concise as possible, and one question per person. All right, so we have three colleagues. Please, let's go ahead with the first question. Just introduce yourself, your affiliation, and your question.
My name is Professor Nkanduluo. I'm a co-chair of Track 6, but I'm from the Global One Health Institute. And my question is to Dr. Mazianga. What I've noticed in our countries is that we are not really looking at the interaction between the environment, animals, and human beings. And the animals are being given antibiotics, our environment, antibiotics, human beings, antibiotics. And my view is that this is really contributing to the antimicrobial resistance. And also our pharmacies are not networked. You can walk in any pharmacy and buy whatever drug you have, prescribed or not prescribed. So I would like some thoughts on what, as Africa CDC, as you address antimicrobial resistance, are thinking. Give me some comfort.
Thank you. So, Mazianga, please note that question. Next.
Good morning, everyone. Thank you for this amazing plenary session. My name is Sheila Isufu. I'm from Mozambique. I'm working in Fundação Auro. So my question goes to the First Lady of Zambia. I would like for she can reflect a bit more and share best practice in how they are overcoming the challenge of the shortcuts on the healthcare workers' load, and to have them providing the best healthcare delivery in a situation that we have less healthcare workers on the field. Thank you.
Obrigado. Next.
Good morning. I'm Baad Nauzad from UK Health Security Agency, and I am based with Africa CDC. I'm going to play the devil advocate here and will pose a question to all the panelists. We talk about financing healthcare systems, innovative ways, and sustainable health systems. The reality is there is only finite resources from any government budget. If they put the money to healthcare, they will have to take the money out of another thing. Either it's education or your transport system or your security or your military or foreign policies and all that. So the money has to come from somewhere, and it's only one pot. Where will it come from? Thank you.
Thank you. So this goes to all the speakers, but I will allow Amit to take the first shot at that question. So, next.
Thank you so much. Good morning, everyone. Good morning, panelists. My question goes to Dr. Lucy. I love the fact that you're talking about MR because this is one of the studies we're doing in Zambia, and part of the facilities we actually did was more focused on antibiotics. What we actually discovered was that 98% of the prescriptions were actually coming from healthcare workers for upper respiratory tract infections. And if you had to ask me, that's actually not necessary. And secondly, when you get into the communities, the patients themselves actually, they put pressure on these healthcare providers that they might provide these antibiotics. Now, looking at AMR as a biosecurity and biosafety threat, how then do we disembark misinformation and disinformation between healthcare providers and the people we give these antimicrobials? Thank you.
Thank you. Next.
Good morning, everyone. Thank you, speakers. I've thoroughly enjoyed the conversation and really appreciating our champion. Back in Kenya, we work with the county first ladies and the first lady at the national level. It's great to see the outcomes of what that kind of engagement can be when it comes to influencing health outcomes, especially for the mothers. My question actually goes to Dr. Amit Thacker. Sustainable financing for primary healthcare. How do we ring-fence the resources that we would get out of especially syntax? And I also appreciate you digging just a little bit into the bonds conversation. How can we make it work? Thank you.
Thank you for that practical question. Next.
Good morning. My name is Dr. Nkemo Keke. I'm the CEO founder of Bind Associates and Medical Links. In my role as a primary care transformation strategist for the Secretary of Health for Maryland, a lot of things that we talked about is to make sure that we treat primary care locally like we treat politics. I think that's one thing we don't do well yet in Africa. We do know that sometimes when you have cold, I have grandma's remedy. We know sometimes when you do have maternal health and a woman gives birth, there's certain things culturally that we do. But when we try to define primary care academically, we kind of put those things aside. Currently, as we speak, in the United States, there's something now called social determinants of health, which has transitioned to Europe as well. But having trained in Africa, I said, this is not new. This is what I learned. But when I came abroad, I was taught to think things were different with different primary care models, patient-centered care models. But that's exactly what we're doing in Africa. So I think I wanted to put that forth, that I think the truth is that we are not looking at what is peculiar to us. Let's incorporate the things that we know our patients do. If I'm sick, I go to the traditional medicine doctor first. So by the time you come to the urgent care center, you've gone through all these other steps. Though that is primary care. We may argue for and against based on research, but how can we incorporate that so we can pull more people in to be part of our primary healthcare delivery transformation?
Thank you. Last but not the least question.
Thank you, all the speakers. My name is Justin Ngofe. I work with APIM Public Health Initiative in Nigeria. So I just want to ask, in many settings, primary health care settings are not working. So maybe my question is to Dr. Amher. I want to know how can we better integrate private sector innovations, particularly diagnostics and digital health, into the primary health care frameworks without losing affordability and then accessibility. Thank you.
All right. Thank you. Thank you. So let's start with Masianga around those questions on AMR. Regulation of our patent medicine providers, One Health approach to AMR, and of course, information management. Over to you.
Thank you very much, Dr. Taj, for giving me the opportunity to respond. Weirdly, Professor Lubo, you are my teacher, you are my lecturer, you are my I guess I'll be tested for the rest of my life. So when we're looking at the interaction between human, animal, and environmental health with regards to AMR, in terms of what the Africa CDC is doing, I think what is important to note is that the Africa CDC recognizes that this is a major problem and we definitely have to action it. And so in our mandate to support member states in strengthening their health security, we are leading some efforts to combat AMR across the continent. And we have actually a framework for AMR control in Africa and some related initiatives. And I'll just summarize a little bit around that. This framework and the initiatives focus on strengthening laboratory capacity in the member states to be able to detect and monitor resistant infections in humans. And remember, in my remarks, I did talk about the genomic surveillance initiative, strengthening this capacity to be able to detect in time, but also enhancing surveillance systems to collect and share data on AMR and antimicrobial use across the countries. It's also focusing on developing treatment guidelines for common bacterial infections to promote rational antibiotic use in healthcare settings. The framework also focuses on supporting national policies and legal frameworks for infection prevention and control and antimicrobial stewardship. We've actually been going to member states to support them in adapting this legal framework that was developed, but also building workforce capacity through training and technical support of health professionals. So while the Africa CDC really focuses on promoting the One Health approach, its human health focused activities aim to really improve the spaces of diagnostics, surveillance, and appropriate antibiotic use in order to reduce the spread of resistant infection. And quickly to answer on the question from my colleague from Zambia, by the way, I come from Zambia originally. To manage the poor prescribing habits and combat AMR, we need good antimicrobial resistant stewardship, and this should be at all levels of healthcare. And this means that we need to promote rational antibiotic use, ensuring clear treatment guidelines, using regular training for healthcare workers, and then also auditing and giving a feedback on the prescribing patterns that are ongoing. But most importantly, in addition, laboratory diagnostics will help us understand what antibiotics are needed for the infections that we are seeing. I see the moderator looking at me, so I have to end there. But public education also remains a critical component in antimicrobial stewardship. Thank you very much.
Thank you, Marcianga. Indeed, Africa CDC is doing a lot as far as AMR AMR control support to member states is concerned. I'll be more than glad to provide more information after this session. So allow me to invite Amit Tucker. A couple of questions for you there. One is around how do you prioritize health financing? I mean, other competing needs, especially social needs, you know, and somebody clearly articulated the importance of social determinants of health. Number two is we've all been canvassing for syntax, right? But how do you ring-fence what is coming from there, you know, and channel that into health? And last but not the least, the role of private sector, especially when it comes to those smart solutions. Over.
Thank you. Taj, thanks for summarizing. We all health champions are here, and we've been, you know, sitting for a few days discussing important topics. My first question is, how many of you believe $1 gives $9 value? If you spend $1 on health, you get how much back? $9. If you believe in that, can you raise your hand? Or even if it's 1 will give you 9 or around 9. How many of you believe that if this was the Ministry of Finance, that if I ask the same question, they would raise their hand? Do you believe Ministry of Finance will also agree that $1 gives us $9 value of return? Do you think they would? And Taj, that's really the issue. I think for us, choices in countries have to be made when it comes to allocating from the one pot. And choices have consequences. And I think what we have not packaged appropriately as champions in healthcare is actually the value of the country's growth and prosperity by investing in health. We've talked to it ourselves. At least 60–70% of the hands went up. There are still about 30% of the people who are not convinced that it's giving 1 to 9. Maybe it might be a bit lower, might be, but in the end, you create a market, and the healthy market is going to drive growth and prosperity of the country. But I am totally convinced that every country has to make priority choices, and I think those are tough choices. This is why I keep saying that healthcare is on the ballot. Your country's elections and the party manifesto has an important design of what matters. So healthcare is on the ballot, education is on the ballot, community awareness is on the ballot, and choose wisely and have leadership as a fundamental choice so that we can bring healthcare on the forefront on the agenda. Second one that Taj you asked was about syntax. How do you ensure you ring-fence those? It's a very important question. The mechanism of how the money flows within the country and the design is as important as the percent of tax, whether it's on oil, health tax, consumerism, is critical. If it starts getting mixed with the general treasury, you will find it very difficult to continuously fight for ring fencing. In some countries, what we have seen is every collection is directed to a separate entity, legislated by parliament, like in Kenya. The payroll tax is deducted at source, but it does not go to the treasury. The funding goes directly to a separate account that is only responsible for health. So the design of the flow of funding will determine if the sin tax is ring-fenced and used specifically for health, whether it's sugar tax, alcohol tax, and so on and so forth. And then finally, the last question was, I feel that the diagnostic question that you brought about was so critical. Connected care and connected health is the next phase of improved primary care. How do we integrate that? I feel we need to create an essential diagnostic list, EDL. All of you are aware of that. And within the EDL, just like the way we have essential pharmaceutical list, we should bring the diagnostic innovations, both in terms of health products that are listed, approved, and be circulated and be within the system. So I think regulation of diagnostic care will be the solution. Thank you, Taj.
Thank you so much, Amit. So let me invite Her Excellency, Dr. Christine. Two questions for you, Your Excellency. Number one, there is, how do we overcome primary healthcare workforce shortage? How do we get more from the little workers that we have? Number two is alternative care. Is it complementarity or is it something else at the PHC level? Over to you, Your Excellency.
Thank you so much for those questions. Let me start with the first one about dealing with burnout and work shortages. Dealing with shortages requires a multifaceted approach. And one of the strategies that were used in Zambia was firstly to recruit and retain a number of health workers. I remember in 2011 there was a critical shortage of health workers. Most of our doctors, most of our nurses were going out for greener pastures. But the government then increased their salaries. For the first time, the salaries in governments were higher than in the private sector. And suddenly we saw a shift of doctors coming back into the public health space. And this was a temporary reprieve, but at least it retained, you know, the cardinal number of doctors. And this was not enough because government realized that we needed to increase the numbers of doctors, nurses that were graduating every year. We didn't have a space to accommodate 1,000 nurses at any graduation. Those were built in older times, and maybe a total number of 30 nurses or doctors were, you know, the space for teaching and everything. So government embarked on building a center of excellence where there will be 1,000 graduates every year. So this, as we mobilized and recruited more doctors, there was this going on, and right now that school exists. And suddenly the numbers are so enormous, so huge, that government cannot even get all of them onto the payroll. Even the private sector cannot have. So we have a lot of volunteer doctors, which I think was also very important, and they played a very cardinal role in the cholera fight. Luckily enough, the current president, Hichilema, was on hand to see that care for the patients was mainly being done by the voluntary doctors, as the other doctors had remained at health facilities to continue caring for the other patients. And he didn't hesitate to pass a decree that government had to open and freeze certain positions and look for money to employ those volunteer doctors. So this happens, and also the present government has been very intentional on recruiting health workers. I was just looking at the statistics, and in 2022, 11,276 health workers were recruited. In 2023, 3,250 workers, and in 2024, 4,140. And you can imagine it's not easy looking for money, but government has been intentional and they've been mobilizing funds to be able to accommodate all these huge numbers. The second strategy is training and development. You know, governments have been intentional in investing in staff training, mentorship. We heard Dr. Mazianga talk about how she was mentored by Professor Luo, and this has been going on. In-service curricula has been drawn up and is being used to upgrade the skills, which also feeds into the quality of care. I think the other issue has been task shifting. There were certain procedures that could only be done by doctors, like evacuation of the uterus for those that had complications of abortions. But we moved away from there and we started training midwives and nurses who were manning the primary health care facilities to be able to manage, you know, patients as they came before they referred them up to the hospitals. And some patients never even required transfer to the next level of care. So this has been done. We needed to start with the law, and the act was passed to allow midwives to be able to do certain things. So task shifting, quite important. How do you ensure quality? We've been using telemedicine, digital innovations. As I talked about the cervical cancer, there was a system that was set up which connected the teaching hospital server to all the primary health centers, such that if a nurse needed assistance in managing a patient, if they had any doubts about the patient, an SMS will be generated, and any doctor, any consultant at the health center will be able to respond to that. So nurses were motivated, and it's nice to feel that, you know, your problem has been answered real time. Otherwise, you know, nurses would have been sending the patients to the hospital and the waiting time was going to be high, but problems were being solved just right there, real time. What we have not done very well in terms of the burnout has been the wellness initiatives. You know, we need to work more to, you know, to care for our own doctors. We have seen them dropping. We have seen them, you know, catching cholera, but we don't do much to care, to offer support, emotional support, spiritual support when they are in trouble. So I think we can do much better like that. But the other strategy has been recognition and appreciation. When somebody has done very well, you know, you commend them, and that motivates them. So those are some of the strategies that we have done to look at, you know, to face the issue of burnout, and also looking at the workload and trying to see how we can move the workload to allow those to go and rest. Although it's not very easy. When you have staff shortages, you know, no matter how you stretch and think that you might get somebody else to come in place, it's not very easy at all. The second question was, just remind me, moderator.
The alternative.
Alternative, yes. I was going to talk about, sorry, I missed, you know, I was so happy when I heard about the manufacturing, you know, centers, hubs, being opened up in Africa. And this is something that we need now to start consider. How do we tap into this indigenous wisdom? We have seen, I mean, I was a gynecologist and I had to deal with patients with severe anemia, patients who are, what do you call the watchtowers?
Jehovah Witness? Is it Jehovah Witness?
They don't like being called watchtowers, but Jehovah's Witnesses, and they don't accept blood, you know. But I saw how they use avocado seed, and you know, patients were on the ward, and you could see the hemoglobin increasing. And we have also learned from China, you know, how they package their medical, the indigenous medical formulations. And I think it's high time as Africa, we actually ventured. So as we are looking at manufacturing Western developed drugs, let's look at our own indigenous drugs to see how we can move forward. Our mothers knew how to treat febrile conversions. They knew how to treat dysmenorrhea. Why don't we do research? So it's a matter of investing in research and development and coming up with all these African-born solutions.
Thank you so much. Colleagues, please join me in appreciating our distinguished panelists. So at this particular junction, allow me to invite Dr. Landry Sagwe to wrap up with a very short presentation. Landry, we appreciate if you can keep your presentation to less than 5 minutes because we have sessions coming up at 11. Thank you.
Good morning. Great. So it gives me great pleasure and great honor to attempt to wrap up this excellent plenary in 5 minutes. Dr. Taj, thank you for the challenge. In few words, what I would like to say after listening to Dr. Hamid, Dr. Kaseba, Dr. Lucy, is that if there's one message that we are all carry on today, is that the revolution that is called by Dr. Christine Kaseba is definitely aligned with the urge to translate our health sovereignty. It's really what we need to affirm our self-reliance. We need a revolution for primary health care, a revolution that will bring domestic financing as a natural act. We should not be asking our government to allocate resources to primary health care. A revolution that will bring our community not only to be at the center of our decision-making, but also as actor in discovering solutions that are locally relevant and that are sustainable. At Africa CDC, that revolution has called for what we are embodying under the PHC transformation. We need a movement that will transform primary health care on this continent as an agenda for health sovereignty. So I think this has now covered my first minute. And for the second minute, I really want to focus on this message. What came out clearly during the conversation today is that the workforce has to be transformed. It is clear that, listening from the example of Zambia, where the government is investing in training and recruiting doctors, the workforce that seems to be protected against brain drain is likely going to be the community health workers. This is what I learned from a discussion with one minister of health. And he told me clearly what they have observed in their country is that across the spectrum of the workforce, The only workforce where the investment is retained in the country is the community health workforce. What does that mean for our PHC transformation agenda? At Africa CDC, we are advancing a community-based primary health care. The 2 million CHW target set by our head of state is a top priority. We have reached half point, we still have 1 million to go. But how are we equipping, protecting, and making the 1 million existing community health workers polyvalent to deliver integrated package at community level, to be the forefront of AMR prevention? Lucy, they have a role to play on AMR prevention, our community health workers. The second pillar of this transformation agenda is on the digitalization as part of a broader transformation of the infrastructure. The multi-sectorality calls for water, sanitation to be central to this infrastructure for primary health care transformation. And Amit was very right when he insisted on leveraging the digital transformation as a gateway. I think in Kenya they call it the superhighway. As a superhighway that will drive this revolution at a faster speed. We must do that. We must harness the power of digital transformation to bring the connectivity from the community health workers or even from the family, because the agenda of digital transformation enables us today to have a digital health card and to cut across the issues of data capturing, to cut across the issues of environmental health connected with animal health connected to human health, the One Health approach. Digital transformation is a game changer. Third pillar, unless we can produce, secure our stock, and make it available at the last miles, we will continue to suffer from stock out in our primary health care systems. We have the solution through local manufacturing, not only for vaccines, but also for diagnostics, therapeutics, and other commodities. I think on the first day, the Director General of Africa CDC, Dr. Jean Kaseya, shared with you that the local manufacturing is an agenda of sovereignty. And the pool procurement is a game changer to address the financial crisis that our health system is facing today. Fourth pillar, the financial access transformation is one where there's a lot of innovations that were discussed during the panel. The bond, coming back to the example of the bond. And Amit, I think you have a lot of work. You need to unpack that further. Beyond the bond, the Green Book that was presented by the Director of Africa CDC at the opening outlined those 3 pillars: innovative financing, blended financing, which will support the drive to achieve the 15% Abuja target for domestic resource allocation. Fifth and not least, the whole quality of care and data, critical as we talk about integrated service delivery, critical as we talk about prevention of AMR, and even more critical if we want to improve quality of care using real-time data. But underpinning all of this is what Amit called leadership, the ballot, governance, yes, critical. Limited resources, we need to enforce governance and accountability. So, these are the few slides that I've also prepared for illustration. One important slide is this one. At Africa CDC, around the digital transformation, we are advancing an agenda where the PHC digitalization package will leverage EHR, electronic health record, the electronic community health information system, and the innovative Africa digital health card. This digitalization will be connected to national health intelligence centers and at continental level to a open knowledge analytics for public health insight that will provide real-time capability to Africa CDC to support member states in disease detection and also in evidence for decision making. I see the moderator is standing. allow me one more slide. The summary of this is this important intelligence ecosystem that Africa CDC, in support of our member states and leveraging the digital transformation, would like to propose as a way to advance community to continental digitalization. Yes, unless we connect our community to a continental system, the continent will not be able to advance a unified momentum for the revolution that is needed around our PHC transformation. I thank you.
Could we give him a parliament clap, kindly? 1, 2, 3, 1, 2, 3. Perfect. Ladies and gentlemen, esteemed speakers, this marks the end of our plenary session today. And my kind request is that I hope as we're going back home in our different workplaces, we will all be champions of primary healthcare. It is the foundation that we will build the health of our different countries. I would like to ask our speakers today to just stand for a picture. Plus me, 1 minute. So that's it. Have a lovely rest of the day, guys.